You just clocked in, and a patient is rushed through the emergency department doors. They are profoundly confused. Their skin is bone dry, and when you glance at the monitor, it doesn't even give you a blood sugar number. It just flashes the word high. I'm Brooke, an ICU nurse and clinical educator. My mission is to help you move past textbook definitions and master the high-stakes decisions you make at the bedside. If you're ready to bridge that gap, hit subscribe. We're decoding exactly what that flashing high really means. The initial presentation is easy to misinterpret. The patient is clutching their stomach in severe pain, vomiting uncontrollably, and panting. If you're working triage, it's natural to think food poisoning or even appendicitis. But look closer at the physical assessment. You'll catch a scent of nail polish remover or overly ripe fruit, the smell of ketones escaping the lungs, and their breathing follows a specific, striking pattern: deep, gasping, and labored. These are Kussmaul respirations, a sign that the body is desperately trying to exhale toxic acid. This occurs because in type 1 diabetes, the pancreas produces no insulin. Without insulin to facilitate glucose transport, the starving cells have no choice but to switch fuels. The liver begins breaking down fat, which floods the bloodstream with red acidic particles called ketones. This is diabetic ketoacidosis, or DKA. The lab work confirms the severity. Blood glucose is elevated above 250, and the surge of acidic ketones drops the blood pH below 7.3. The patient's bicarbonate, the body's chemical buffer, is depleted below 18 as it tries to neutralize the acid. Finally, the anion gap mathematically proves there's a significant amount of hidden acid circulating in the blood. DKA is a rapid, violent acid crisis. Without immediate intervention to reverse this chemistry, organ systems will begin to fail in a matter of hours. Let's reset the scenario. We're back at the moment of admission, but we are changing one single physiological variable to see a different emergency unfold. In type 2 diabetes, the body maintains a relative level of insulin. There is enough insulin present to allow a small amount of glucose into the cells, which is the threshold needed to prevent the liver from switching to fat-burning mode. Because fat isn't used as a primary fuel source, the acidic ketone particles never form. However, because insulin levels are still insufficient to process all incoming carbohydrates, the unabsorbed glucose relentlessly piles up in the bloodstream. Over days or weeks, the blood thickens into a highly concentrated hyperosmolar syrup. This is Hyperglycemic Hyperosmolar State, or HHS. You won't find the fruity breath or the gasping respirations of DKA. Instead, the thick blood triggers a massive osmotic diuresis. The kidneys desperately try to pee out the excess sugar, leaving the patient with sunken eyes and bone-dry skin. The neurological impact is driven by that syrupy blood acting like a vacuum. It creates an osmotic gradient that pulls water out of the brain tissue and into the blood vessels, physically dehydrating the brain cells from the outside in. As those cells shrink, electrical signaling is disrupted, leading to severe confusion, seizures, or coma. The labs for HHS show a distinct profile. Blood glucose is often extreme, reaching well past 600. The serum osmolality is elevated above 320, yet because there are no ketones, the blood pH remains in the normal range. This comparison highlights the tactical difference. DKA is a rapid acid attack. HHS is a slow, insidious dehydration burn. One requires clearing acid. The other requires massive rehydration. Regardless of the diagnosis, the treatment follows a strict 3-step sequence. Deviating from this order can cause iatrogenic harm that is as dangerous as the original condition. The first priority is aggressive volume resuscitation. You hang 0.9. If the vascular tank isn't full, the blood vessels will collapse and the patient will enter hypovolemic shock. The second priority is securing the potassium level. It must be safely above 3.3 before you touch the insulin drip. Insulin acts as a dual transporter. As it moves glucose into the cell, it simultaneously activates pumps that pull potassium out of the bloodstream. If the patient's potassium is already low, starting that drip will cause blood levels to plummet, triggering lethal ventricular arrhythmias. Only after the vascular tank is resuscitated and potassium is secured can you move to priority 3, initiating the IV regular insulin drip. Understanding these physiological priorities ensures you are managing the patient's stability rather than just reacting to a single high lab value. As the blood sugar drops to 200, the protocol requires a counterintuitive shift. You must change the IV fluids to a bag containing dextrose, essentially sugar water. Feeding sugar to a hyperglycemic patient provides a critical buffer. It allows you to keep the insulin drip running long enough to clear the remaining acidic ketones from the blood without crashing the blood sugar. Think of the insulin as the engine and the dextrose as the landing gear. You need both to bring the patient to a safe, stable blood pH. The final step is the transition off the IV pump. IV insulin clears the blood in minutes, but a subcutaneous injection takes hours to reach therapeutic levels. You must administer the sub-Q shot 2 to 4 hours before turning off the pump. This overlap ensures there is never a gap in insulin coverage, which would otherwise trigger a rapid DKA rebound. While you manage the fluids, you must also investigate the why. Use the 5 I's to hunt for the trigger, often a silent infection like a UTI or pneumonia that launched the hormonal stress response in the first place. DKA requires rapid acid clearance. HHS requires profound rehydration. But both demand the strict sequence of fluids, then potassium, then insulin. Mastering these mechanics allows you to anticipate fluid shifts and electrolyte crashes before they destabilize the patient. This precise management is what protects the patient from cardiovascular collapse and leads to a safe recovery. If this look at the bedside logic was helpful, subscribe for more clinical breakdowns. Tell me in the comments what complex topic you want us to simplify next.